So we are going to discuss INI-CET May 2025 questions. They are not the real questions, they are the questions which are made according to the questions which are asked in the exams. For the understanding of the concepts, we are discussing all the questions here. So we had around 26 questions in surgery. As usual, general surgery and trauma had a major part. So all the following are true regarding tension pneumothorax except. Please remember, tension pneumothorax related question. A common cause of tension pneumothorax is positive pressure ventilation. When we connect the patient to ventilator and the positive pressure ventilation is going on, the bulla in the lungs can rupture and can cause tension pneumothorax. That is true. Thoracic rib injury. Yes, thoracic rib injury can perforate the lungs and can cause pneumothorax. Breath sounds are affected on the are absent on the affected side. That is a clear-cut answer. So true regarding tension pneumothorax. I am sure there are 3 answers are correct. Simple pneumothorax cannot convert to tension pneumothorax is wrong. Simple pneumothorax can suddenly become a tension pneumothorax also. So most common etiology for tension pneumothorax is a penetrating injury. This happens due to fracture of the rib, causing parenchymal injury. It can also happen in air leaks. Simple pneumothorax that did not close spontaneously can go for tension pneumothorax. Iatrogenic injury due to central venous catheterization, intermittent positive pressure ventilation during anesthesia, all these things can cause tension pneumothorax. Breath sounds are absent and mediastinal shift will be there. There will be absence of breath sounds and the mediastinum will be shifted to the opposite side. Please don't forget, it is a clinical diagnosis and no waiting advised for radiological confirmation. Immediately take a needle and put it in the 5th intercostal space mid-axillary line. It's a serious emergency. Okay. Which is not correct about vacuum assisted closure device. So you have been discussing this VAC device for long period. It's a very important topic. You know that in a wound, for example, if there is a wound, we keep a gel foam like sponge over which we keep a suction and over that we put a plastic sheet. That is called as vacuum assisted closure device. It will suck out the excess fluid, excess debris and all will be sucked out at a pressure of minus 125 millimeters mercury. It reduces the bacterial load. The answer for this, it reduces bacterial load. Yes, it is true. Continuous or intermittent negative pressure is applied. Yes. It helps in the healing of the wound and granulation and reduces the edema. So from the 4 choices, all are true. There is nothing wrong in this. So negative wound therapy or vacuum assisted closure device uses intermittent or continuous pressure up to minus 125 millimeters mercury. So all the 26 questions are there in Bayesian law. That is the most important thing I want you to know. See, surgery questions, there is no controversy. All of them will come only from Bayesian law. Okay, this year we had all the questions including the images from Bayesian law. So it is minus 125 millimeters mercury through a sealed foam dressing in order to stimulate the formation of granulation tissue, reduce local edema, reduce bacterial load also. It reduces local edema, bacterial load also. The technique has numerous applications including a dressing to secure a skin graft to its recipient bed, temporary coverage of a complex acute wound as an open wound until definitive cover can be achieved, or to manage chronic wounds like pressure sores. Please remember, this is now the treatment of choice for diabetic foot and bed sores. Now, vacuum assisted closure device plays a major role in diabetic foots and bed sores. By the plastic surgeons, they use it in many places. This is a new question from Bayesian law only, not from any other book. It is a picture showing you what is this procedure shown here. Choices are incision and drainage, split skin grafting, keloid excision, dog ear correction. Please understand, if I close an elliptical wound like this, if I am closing an elliptical wound like this, at the end of the elliptical wound closure in the skin, the elliptical wound might have an excess skin on both sides. This is called as dog ear. So dog ears are lifted with a hook, skin hook, and cut like this and suture. That is the image. It is a dog ear correction, direct image from Bayesian law. So dog ear is lifted with the skin hook and excess skin is cut and we close it like a cosmetical method. This is called as dog ear. A patient with history of chest trauma and breathlessness is found to have systolic BP 90, saturation 85, GCS 8/15, absent breath sounds. Absent breath sounds, saturation is falling down, BP falling down. What will you do next? Simple question. The question is asking the protocol ABCDE protocol. Airway, breathing, circulation, disability, exposure. So what should I do first? So I should secure airway, put a needle and start IV fluids according to this. A for airway, breathing, needle is inserted because patient might be having a pneumothorax, needle insertion, and circulation IV fluids. That is the order we should follow. So this question is about the primary survey ABCDE. So as per that, we have to secure airway first, followed by needle thoracotomy and circulation by IV fluids. Okay, IV fluids are given as a last, as a third. Okay, this is the basic concept for any trauma management. So therefore, we had some 4 questions from general surgery and trauma, equally distributed. This year, the paper is equally distributed questions from various sections. So we usually discuss in our regular module in 5 sections. Same way I am discussing the topics under 5 sections. So head and neck, thyroid, breast, final year clinical case topics. Based on the X-ray image provided here, you can see a osteolytic secondaries in the skull. Which thyroid malignancy will have this osteolytic secondaries? Very simple. It is follicular cancer as pulsatile type of osteolytic secondaries. It's a repeat question. It's there, direct line from Bailey and Love. Please don't forget this. So, breast conservative therapy is an updated topic in new edition, 28th edition Bailey. Which of these is not a contraindication to breast conservative therapy? Which of the following is not a contraindication to breast conservative therapy? So, breast conservative therapy is a surgery in which if there is a tumor, we do a wide local excision of the tumor like this, and followed by wide local excision, we give radiotherapy to remaining breast. And if there are nodes in the axilla, we have to either do, if no nodes, sentinel node biopsy. If axillary nodes are present, axillary dissection is also done. So the breast conservative therapy is not a single step. It is a wide local excision giving 1 centimeter margin, giving radiotherapy to the remaining breast and removing the axillary nodes, and follow-up of the patient considers breast conservative therapy. And what is the contraindication of breast conservative therapy? If a patient previously had radiotherapy to the chest, we cannot use it. If there are 2 times the margin, which I am taking out the wide local excision, 2 times margin positive, it is a contraindication of this breast conservative surgery. Scleroderma and collagen vascular disease are all contraindications to radiotherapy. So, the limited to 1 quadrant we can do breast conservative therapy. This is a direct paragraph from Bailey and Love. BCS is best avoided in patients who are having multicentric tumors, diffuse tumors, a large tumor and a small breast, 2 times margins are positive, history of previous radiation, SLE or other collagen vascular disease, as these patients have high risk of radiation, ankylosing spondylitis, where you cannot put the patient in proper position for radiotherapy. It is also avoided in people who are having orthopnea, because as the patient cannot lie on the radiation table for a long time. So these are the places where BCS is contraindicated. BCS is contraindicated in places wherever radiotherapy is contraindicated. Don't forget this basic rule. So stage T4B, I always say in our regular class, breast cancer staging will definitely come in any exam. So therefore the exam, whichever you study, there will be a question on staging of breast cancer. So T4B, which is not included. So no, don't forget, T4B is a tumor involving into the skin. T4A is chest wall. T4B is skin, which means pituitary orange, limited pituitary orange, satellite nodules, ulcer are all included. So when a skin erythema is more than 1/3, it goes for T4D. That is the direct line from Bailey and Lowe. So T4D is inflammatory cancer, purity orange involving more than 1/3 of the breast. So that is called as T4D. T4B is ulcer, satellite nodules, edema including purity orange. That does not meet the criteria of inflammatory cancer. Inflammatory cancer means more than 1/3 of the surface of the breast. So if there is more than 1/3 of the surface having purity orange, it goes for T4D. Therefore, T4B is purity orange less than 1/3. Okay. So the mammogram and histopathological picture of a woman with the breast cancer is given below. She had undergone mastectomy. Her aunt died of cancer. Which test will you do in the sister of the patient? So this patient is having a tumor. This is a calcification. Branching calcifications. Mammography shows tumor. Shows cancer. So aunt died of cancer. So there is a family history of cancer. So what will you do for this case? So I should check for BRCA1 mutation. This is also there in Bailey. Indications of genetic risk evaluation. An individual at any age with a known pathogenic, likely pathogenic variant of cancer. Any age with a gene problem. Breast cancer diagnosed less than 50 years. Triple negative breast cancer less than 60 years. 2 breast cancer primaries. Breast cancer at any age with one or more relative with a breast cancer aged less than 50 years. Or ovarian cancer, male breast cancer, pancreatic cancer, breast cancer at any age with the 2 or more affected relatives. Any age with the 2 or more affected relatives, male breast cancer, and any individual with a family history of 3 or more of most of the cancers are given here. So 3 or more of the following like breast cancer, sarcoma, brain cancer, colorectal, endometrial, thyroid, kidney, skin cancer, lobular cancer, diffuse gastric cancer. So 3 or more any cancer also you can undergo BRCA screening. So not only BRCA, any indication of genetic risk evaluation is this. And you all know very well the most common genetic mutation causing breast cancer is BRCA1. Okay, don't forget this basic point. A person living in an iodine deficient area developed hyperthyroidism after taking iodine supplementation. So this is iodine induced hyperthyroidism is called as Jod-Besido effect. So Wolff-Chaikoff and Jod-Besido's toxicosis. Wolff-Chaikoff effect is rebound hypothyroidism. So after taking iodine, there is a rebound hypothyroidism is called as Wolff-Chaikoff effect. Jod-Besido is hyperthyroidism due to excess iodine. So rebound hypothyroidism due to iodine is called as Wolff-Chaikoff, and Jod-Besido is hyper due to excess iodine intake. When a patient takes more thyroxine, that is called as thyrotoxicosis factitia. Due to excess thyroxine consumption is called as thyrotoxicosis factitia. So equally we had around some few questions from head and neck, thyroid and breast topic. Now we will go to the GIT. A 20-year-old female has fever, nausea, rebound tenderness with the migration of pain to right iliac fossa. Laboratory investigation shows leukocyte count elevated. What is the Alvarado score? So Alvarado score you know very well. The mnemonic is MANTRALS. Migratory pain, anorexia, nausea, tenderness, rebound tenderness, elevated temperature, leukocytosis, shift of neutrophils to left. So let us see the points now. Patient has temperature is 1 point, nausea 1 point, rebound tenderness 1 point. With the migration of pain, that is another 1 point. WBC count is increased. So among this, WBC count has 2 points and tenderness also has 2 points. So therefore, what is the total score? 2 plus 2 plus 4 plus 3. So elevated temperature is given, nausea is given, Rebound tenderness is given 1 point. Temperature is not mentioned here. Elevated temperature, it should come for T for tenderness. Elevated temperature gets only 1 point. So total points are 6. So this is a little easy question, but you have to spend some time calculating the score. So very classical question. So what are the things which will have 2 points in this means? Leukocytosis and McBurney's tenderness. So these two guys have 2 points. All others have 1 point. So the total score here is 6 out of 10. So what is this investigation modality shown here? This is a new updated question combining radiology or surgery somewhere. This question has been asked. In this question, we have given the contrast through the rectum like this. And we are allowing the patient to go for motion. As the patient is going for motion, you can see there is a descent of the rectum internally. So it is mainly used to diagnose internal rectal prolapse, sigmoidocele. It is an X-ray. Basically, this question is asking whether it is an X-ray or MRI or a CT. It is a very simple X-ray defecogram. It's an X-ray defecogram. That's all. MRI, CT, X-ray. How will you differentiate? That's the question. This is an X-ray defecogram used to differentiate, diagnose rectocele and internal rectal prolapse. It's an obsolete investigation. Nobody does this because we have MR defecography now. Nobody uses this X-ray defecography. So please see, this is also taken from Bailey law. For your understanding, I want you to tell all the questions are from only Bailey. Visualization of the rectum is achieved by barium impregnated synthetic stool using conventional defecogram. You can see this is the conventional defecogram. This is the MR defecogram. Large rectocele, this is a rectocele is apparent. Large rectocele is found on defecogram. In both the pictures, you can see the rectocele. Okay, so this is a classical MR defecography and a X-ray defecography pictures. Okay, a male patient with diarrhea since 8 months with the shown CT scan, a loss of hostrations in the right colon. See, I am not going to the image, but I am going to study from the history itself. Patient has diarrhea. CT scan shows loss of hostration appearance. See, this is hostration. This is hostration. If these hostrations are lost, it looks like a lead pipe colon. This is called as a lead pipe colon. So the question is asking what is the most likely diagnosis? See, there is a point here is there are 2 choices in this. Ulcerative colitis also has lead pipe. Crohn's also can have lead pipe. But ulcerative colitis, you can see here in this picture, this is right side colon. In the left side colon, can you see the lead pipe colon? So lead pipe appearance is seen both in ulcerative colitis and Crohn's disease. There is a loss of hostration. If it is seen involving right side and left side bowel, it is usually ulcerative colitis. Crohn's involves most commonly ileocecal junction. Colon involves most commonly rectum and the colon and left colon. Okay, this is very basic thing. Should know where is the loss of hostration. So from the history and the picture they have given, it is mostly an ulcerative colitis because there is no skip lesion. There is a continuous lead pipe appearance. A female presents with the bleeding per rectum. Mass is seen 6 cm from anal verge. The tumor shows intramucosal cancer. See this. Usually the staging of stomach cancer, breast cancer and oral cancer only they will ask. This time they have asked staging of colon cancer also. Please remember, first time the question comes from colon cancer staging. So what is the staging for an intramucosal cancer? It is stage T stage 1. Let us see what is it. So stage 1, this tumor is stage 1. Tumors involving mucosa and submucosa is T1. T2 is tumor involving muscularis layer. T3 is tumor involves subserosa or non-peritonealized pericolic tissues. Non-peritonealized pericolic fat and all. T4A is it breaches visceral peritoneum. T4B is adjacent organ. N1 is 1 to 3 nodes. N2 is 4 or more nodes. Now coming to the stage. Stage 1 is T1, T2. That is nothing but mucosa, submucosa, muscularis propria is stage 1. Stage 2 is subserosa, serosa and adjacent organ involvement is stage 2. Stage 3 is any node positive. Let it be 1 node or 6 node, it is stage 3. Stage 4 is METS. So from the question you can see it's an intramucosal cancer. So I will go for stage 1. That is the staging of TNM staging of this cancer. Actually there is another question. We don't know whether there are two different questions or it is only the same question. 62-year-old man is diagnosed with a colorectal cancer. Histopathology reveals the tumor has invaded through muscularis propria, but there is no lymph nodes or distant metastasis. And in this question, they specifically asked Duke staging. What is the most appropriate stage? According to Duke staging, muscularis propria invaded means it comes under stage B2. Please see this Duke staging. It is a little different. It is not like TNM. TNM is easy to remember. Dukes is little difficult and actually we don't use Dukes. Dukes A limited to mucosa. B1 extends into muscularis propria but not beyond it. B2 penetrates through muscularis propria. Okay, B1 up to muscularis propria, B2 beyond muscularis propria. And C1 is B1 plus nodes. C2 is B2 plus nodes. And D is distant METS. So this is a Duke staging. So please go through this Duke staging. Extends beyond the muscularis propria becomes B2. So this is a new question. Again, first time asked question in INICET. Chronic pancreatitis, the score used is Mannheim score. That is true. It is there. Achalasia, the classification used is not Los Angeles. Los Angeles is a classification of reflux esophagitis. For colonoscopy, we use a score to say the preparation that is called as Boston score, and for parathyroid, we use a Miami criteria. So Mannheim score. Mannheim multiple risk factor for chronic pancreatitis. It is based on Mannheim is a mnemonic. M for multiple risk factors. A, alcohol. A, N, nicotine. Another N, nutritional, high caloric proportion of fat and protein. H, hereditary. E, efferent duct factors like pancreatic pathologies like pancreas divisum and all. I for immunological like autoimmune, and M for miscellaneous. This is called as Mannheim classification. So Mannheim multiple risk factor classification. M for multiple risk factor, A for alcohol, N for nicotine, another N for nutritional, H for hereditary factors, E for efferent duct factors, I for immunological, and another M for miscellaneous. So this is out of syllabus from our Bailey. This is not there in Bailey. It is out of syllabus. But answer is easy to understand. No? From the picture you can say, from the topic you can say achalasia, nothing to do with Los Angeles. We have discussed it. In reflex esophagitis only we have Los Angeles. So the answer is B is wrong. Okay, other things are correct. Identify the bariatric surgery in the given image. This is a 28th edition update. So whenever we say we have to read the new edition, this is a main reason. 28th edition has added one extra surgery in bariatric that is called as SADI. Single anastomosis of duodenoi-ileal, single anastomosis of duodenoi-ileal and sleeve gastrectomy. Along with sleeve gastrectomy. This is called as SADI. So you can see duodenum is anastomosed with the ileum and we have removed the part of stomach. This operation is called as SADI operation, new update in Bailey and Law. So these are the two various commonly done operations. The first picture shows biliopancreatic diversion with a duodenal switch. I request you please go through the images alone. Biliopancreatic diversion with a D1 anastomose to ileum like this. It is two anastomoses. See, here there is one anastomosis, here there is ileo-ileal, another anastomosis. So, bilio-pancreatic diversion with the duodenal switch operation. This is first picture. Second picture is SADIS operation. Single anastomosis. There is no two anastomosis. The duodenum anastomosed with ileum directly. So, the proximal anatomy looks same. We have done a sleeve gastrectomy. We have cut up to D1. But here we directly did a one anastomosis with the ileum. Here there are two anastomoses. 1, 2. This is SADIS. So, definitely you can get this question also as a picture-based question. Please remember this also for your exams. That completes the G80. We had around 6 questions. Which of the following is not a boundary of hepatocystic triangle? So, very well known, controversial question. We were waiting for this question because many times the anatomy faculties would have told Calot's triangle as hepatocystic triangle. Calot's is different. Hepatocystic triangle is different. Hepatocystic triangle is bounded by liver, common hepatic duct and gallbladder with cystic duct. This is called as hepatocystic triangle. Bound by liver, common hepatic duct and cystic duct and gallbladder. Such a big triangle is called as hepatocystic triangle. Inside that we have a small triangle bounded by cystic artery, cystic duct, common hepatic duct. This is called as Calot's triangle. So, Calot's triangle is bounded by CCC. Cystic duct, cystic artery, common hepatic duct. Hepatocystic triangle needs liver as a boundary. Cystic artery is not a boundary, it is a content. Hepatocystic triangle, cystic artery is a content. So much upset seeing the paper. There is only one question from hepatobiliary. Specialty surgeries had a lot of questions and most of them are straightforward questions from Bailey and Lowe. Most useful investigation for localizing parathyroid adenoma is classical picture showing you sesame scan. It's not an image-based question. They just asked a direct question. Investigation of choice to locate parathyroid adenoma is sesame scan. Imminent gangrene in the peripheral vascular disease is associated with an ankle brachial pressure index. Normal value is 0.9 to 1.1. Okay, 0.9 to 1.1. If the ABPI is less than 0.9, there is a peripheral vascular disease. And if it is less than 0.4, we call it as critical limb ischemia. So, normal value less than 0.9 is peripheral vascular disease, 0.4 is critical limb ischemia, and values more than 1.4, false high values. False high values are seen in sclerosed vessel, calcified vessels. So, in this, we will go with a D, 0.3. What is Insert-Plasty technique used for? So, equally the distributed questions from each specialty, one question. So, Insert-Plasty is a technique especially used in burns. They have a neck contracture. We put an Z-shaped incision and close it like an S. Z becomes S, the contracture extends. So, technique for Scar-Lengthening is called as Insert-Plasty technique. It's a very common question. Recurrent urinary stones are seen in following except. This is a 28th edition update. 28th edition updated question. Hyperoxaluria, uricosuriا, calciuria will cause stones. Whereas citraturia, hypercalciuria, hypercalcemia, oxalate, hyperuricosuria, hypocitraturia. Citrate is less means it can predispose to stone formation. So, hyperuricosuria causing uric acid crystals, especially in acidic urine over which calcium oxalate crystals aggregate. So, these are all risk factors. So, calcium, hyperoxalate, uric acid, all these are risk factors. Inhibitory factors are citrate. Citrate is an inhibitory factor. Potassium, magnesium, Tom Horsfall protein, pH. These are the inhibitory factors. Please remember this for future exams. Citrate, potassium, magnesium, Tom Horsfall protein and pH changes are all inhibitory factors. Citrate is protective against the stones. Citrate in the urine is protective. Hypocitraturia can cause stones. Most common pituitary tumor in clinical practice is very simple. It is prolactinoma. You know that very well. In practice, the most common pituitary tumor is prolactinoma, which is also called as functioning adenomas. Functioning adenomas as the best answer here in this picture. Microadenomas less than 10 mm size are usually incidental or with any endocrine effects. Macroadenomas more than 10 mm will come to you with the visual defects. See, pituitary fossa, if there is a small tumor, it comes because of the endocrine. Prolactinoma comes to you with the prolactin secretion and breast milk coming out. Macroadenomas will come to you with the visual abnormalities. So 30% of the adenomas are prolactinomas. Please don't forget this. 20% are non-functioning. 15% secrete growth hormone. 10% secrete ACTH. This is a direct line from Bayesian law. So the most commonest is 30% of them is functioning adenoma called as prolactinomas. Second is non-functioning, which is 20%. Okay. A patient with ureteric calculi is evaluated, which is the investigation of choice to diagnose the ureteric stone. Non-contrast KUB. That is a direct line. So, radiograph of the kidney, ureter and bladder and ultrasound are the first line test. Non-contrast CT is the investigation of choice to diagnose the stones. It allows for diagnosis of both radiopaque and radiolucent stones with exception to indinavir stones. It allows for diagnosis of radiopaque and radiolucent stones. Only indinavir stone may be difficult to find out. Otherwise, even radiolucent stones can be found on non-contrast CT scan according to this line in Bayesian law. Which of the colloid is used in resuscitation as per Muir and Barclay formula? So, most of you would have read Parkland formula. Parkland formula is for crystalloids. We use ringer lactate. Muir and Barclay is for colloids. So the commonly used colloid now is different, but the original they are asking, the original Muir and Barclay formula used fresh frozen plasma as the colloid of choice. But we can also use albumin or fresh frozen plasmas are maintained in the blood bank and are more expensive. Therefore, the most commonly used colloid now is human albumin solution. The question is asking, what is the colloid used in Muir and Barclay formula? The answer is fresh frozen plasma from a direct line from Bayesian law. So, what is used by Muir and Barclay during that formula time is FFP. But what we are using now is human albumin. So, human albumin solutions are better used now. Plasma proteins are responsible for inward oncotic pressure that counteracts the outward capillary hydrostatic pressure. Albumin should be preferably administered after the first 12 hours. You know that very well. Colloids should be given only after 12 hours. Don't give it in the first 12 hours. Due to increased permeability, the patient can develop leaking capillaries and cause severe edema in the face. Everywhere you will get edema. Okay. Again, this is a new. So, see, this time they have gone into the depth of the burns. So, Muir and Barclay formula related question was asked. And they asked a question on Lund and Browder chart. This is not rule of 9 question. While cooking in the kitchen, a sudden cooker blast led to the face with the sinking of the eyebrows, bilateral upper limb and front of chest and abdomen. So, the point is you cannot apply a rule of 9 in this. Rule of 9 is a crude basic rule, but just let us see with the rule of 9 what happens. Face, sinking of eyebrows means burns in the face. Upper limbs, bilateral upper limb. So, each 9. Front of chest and abdomen, it is around 18%. So, 18, 36 and it comes around 45% with this. But this question is asking from Lund and Browder chart. Let me go with the Lund and Browder chart now. Face in an adult is only 3%. See, adult with the face burns is only 3% according to this chart. Adult with the face is only 3%. Upper limb is, it's same, it's around 9%. Both upper limb is 9 plus 9. And front of chest and abdomen, you can see it is not 18%. It is 13%. So, the point here is face 3%. To upper limb comes around 16% and front of chest is 13% and the total percentage falls only to 32%. So, it comes according to Lund and Browder chart. London-Browder calculation, it is only 32 to 36%. If I go with the rule of 9, if I apply, it is an extensive rule. See, 9% is too much for an adult. It is only 3% from the chart. That is the point here. You should remember, London-Browder chart is the most accurate chart. Actually, the examiners should put a line whether it is asking from London-Browder or from rule of 9, because rule of 9 is easy to remember. This London-Browder you cannot remember. It is very difficult. It is printed in the case sheet. We use the case sheet and mark the percentage of burns. It is highly unethical to ask questions from London-Browder chart. But there are questions coming from London-Browder chart for the past few years in INI-CET. Which muscles must be primarily corrected in a cleft lip surgery? So, cleft lip surgery, you should know what is the muscle in the lips. So, what is the muscle in the lips? You should not forget it is orbicularis oris. It's a simple applied anatomy question. It is not even a surgery question. This is an orbicularis oris muscle which is around the lips. I don't know why you have a confusion. There should be no other muscle should come here. Orbicularis oris is the only muscle which is for spouting action of the lips. So, orbicularis oris is a muscle which should be primarily corrected. There may be other muscles involved like nasolabial muscles like transverse nasalis, levator labii, orbicularis ori, labiomental, depressor anguli oris, depressor labii oris, mentalis. All these are muscles, but the primary muscle which should be corrected in cleft lip operation is orbicularis oris. Okay, this is a very simple question, straightforward applied anatomy question. They are just asking which muscle will you correct in a cleft lip. Cleft lip is involving the lip muscle mainly. Therefore, I should first of all correct this orbicularis oris. Afterwards, you can correct whichever muscle may be affected like depressor labii, depressor anguli, mentalis and levator labii superioris, levator anguli oris. All these things you can correct afterwards. But most important muscle to be corrected is orbicularis oris. This is a new question asked in the exam. So, these are the 26 questions in surgery. I can say this paper is a moderate paper, not a very easy, not very tough also. It's a moderate paper, INI-CET paper. You should have left at least in this 26 questions, you should have left 4 questions for a good ranking. So, if you have attended all the 26 questions, definitely 2 questions are new and 2 or 3 questions are totally new and you would have got into trouble. So, thank you. See you in another session. Bye.